community effort in, and people lost weight, the heart disease problems went down, and it was very effective. In the report I've just mentioned, where I dissected well-being and published a month ago, I had a whole chapter about mental health and work, showing how many people suffer from mental ill health, and how if they fall out of work, if you don't intervene with active treatment and help, those people are likely to stay out of work for a very long time. And if they're out of work for over 6 weeks, they stay out of work for 5 years. And what a loss that is to that individual, to that family, to the community and our economy. So I did a big piece around mental health at work and what people need to do. So let me put what I'm doing into context. Oops, I've gone the wrong way. Sorry, usually better than that. So I am, as you heard, the first woman. I am, since the first scientifically active, I was going to say literate, but I don't think my predecessors would like that. And I have tried to go about this role in a different way, bringing science much more into it. And one of the pleasures of my role is to publish an independent annual report. And as I surveyed the annual reports that we have going right back 155 years, I see that they play two different and distinct roles. They play a role, of surveillance, the state of the nation's health, and they play an advocacy role. So I'm doing 2 volumes each year. One is surveillance. It's very data-driven. I get lots of people to help with that. And my role is bringing together lots of data that is out there, but people may not have access to. It's about transparency of government data, putting it together in a way that it wasn't. And then trying to use innovative visualization so it's helpful to people, and making it available for local analysis by public health people so they can plan their services better. The second one, I'm doing a deep, in-depth review of issues. And what I'm doing is getting together a group of scientists, talking it through with them. They write the chapters, their names go on it. And my role is not only to choose the subject and invite them, it is then, following workshops and discussions, to write the policy bit about that. What does what they're saying mean to us as a nation from the policy perspective? And I'm going to take you through some of this so you can see it. The reports go back to 1877, and only in the war, 1939 to 45, was the one report covering those 4 years. Otherwise, there's been one. And if I talk quickly about my first report, we used the international burden of disease categories and looked in surveillance ways at that data. And whoops, I went too fast. And if you look at the left graph here, you'll see how data is normally shown on maps. That's a standard map called a chloropleth, I discovered. And what you'll see is, in all the maps I show you, where it's dark, it's worse outcomes for people. Where it's pale, it's better. And if it's white, the data's missing. What we've used is social geography techniques of cartograms, shown here on the right, where the size of the map relates to the size of the population. So you're beginning to see England in a very different way. What this also reminds you is I'm the head of public health and the CMO for England, but the UK senior medical advisor. It's complex. But anyway, so you will only see data on England in this way. This slide happens to show you smoking-related mortality by local authority. And on the left, you could see that in the northeast, there's a bad patch. And around in London, the kind of down left of centre, no, right of centre, it's not very good. But the minute you blow this into a cartogram, you see that the north, we have significant populations with significant mortality. And it changes how you see it. So we've used these. They come from Danny Dorling, this software. He's a social geographer in Sheffield. And I'd followed his career for years. Here's life expectancy from birth in England and the EU countries. And England is the kind of nice blue that you can see at the left-hand end of those lozenges. Spain's the kind of purpley blue at the right-hand end. And you can see it's gone up over the decades for all of us. But then if you look at the cartogram of the average annual mortality, you can see it hasn't gone up as much for some parts of Britain as it has for others. Again, the northeast, the northwest, and some bits of the east of London. And when they have red edges, they're significantly worse than the average. And that, if you begin to look through the whole of that volume, it's all on the web, I had understood about inequalities and poverty and the impact on health. But for me, it was frankly shocking as we put these maps together and we saw it. So it didn't just wake me up, it woke a lot of other people up. Here's obesity, as you all know, associated with increased risks of heart disease, diabetes, high blood pressure, therefore stroke and cancer. And you can see, again, the northwest, the northeast, and bits of London. Actually, what that cartogram is showing you is obesity in 4-year-olds as they go into school. And it's not too bad. Interesting, I picked that one out, because if you look at obesity in 11-year-olds as they leave primary school and move to secondary school, they're fat. So they go into school not too bad, and they come out fat. It is one of my worries. And if you look here, you can see the Canadian line is kind of flatlining, not too bad. But England, we are second only to the States, which is the top line in the increase in obesity and our projections for the future and what it means. And the cost to our nation is absolutely dramatic. In my latest surveillance report, I've tried to show this in different ways. So using infographics, which we tweeted on the day and were retweeted. And on the left, you see an infographic about obesity, and the red figures are obese, green are overweight, blues healthy, and then blacks unhealthily skinny. And what we were trying to do was to show people in a visual way what was going on. And on the right, what you see is alcohol consumption. And what that tells you is something quite different from the general alcohol drinking levels in the population. It shows you that 40% didn't drink last week, that this is a minority who overdrink, who are damaging their health, while most don't. We've used infographics in different ways. So here is one from my infection report that I'm about to talk to you more about. And what it's showing you is infections linked to travel history. And where it's dark in the circle, we know that there was a travel history out of England. And then the paler penumbra, we don't have that reported history, but we know that they probably did because of the actual infection. So it begins to show people different ways of looking at things. So I wanted to show you what I've been doing and how I've been trying to get scientific data together and show it differently to a broad variety of audiences, including my ministers. But the first in-depth report I chose to do was infections. Now, let me be honest, I chose infections because I thought they were non-contentious. They took me from community through to very high-tech sick people in intensive care units. So it was broad, it affected everyone, and we all knew what to do, didn't we? And I was totally surprised when they all came back with their chapters to tell me what their data showed and what they were doing, because I'd taken this collaborative approach. And what I heard was that when I had given up clinical medicine and looking after patients, predominantly patients with sickle cell disease, as a matter of fact, that antimicrobial resistance was an issue, but that it had gone on getting worse. And it is now out of control. And I said to them, so, okay, so you're all expert, and you tell me this. Haven't you said this before? And said, yes, and we've had 2 resolutions at the World Health Assembly, and we keep telling people, but nothing's happened. And I thought about it, and I remembered that in Britain, the power in health is held by the academic medical community, and we've disinvested in academic microbiology. I don't know why, but I had seen it happen. I am now concerned what else has happened on our generation's watch that we haven't recognised, but I won't go there at the moment. So we have seriously competent microbiologists, but not able to get a voice because the power bit wasn't there. So they'd been saying this, and no one had taken any notice. And you know, it isn't new. When Alexander Fleming picked up his Nobel Prize, he actually talked about how bugs would develop antibiotic resistance, in his case, of course, penicillin. And I realised that I was going to have to raise this and make some recommendations. And my strength may not be in public health, but one of my strengths is that I actually have taken the trouble to learn the system and how to work it. So one of my recommendations was actually that what we should do is put antimicrobial resistance on the government risk register next door to terrorism, pandemic flu, and climate change. I'm pleased to tell you, though it takes a long time, that's going to happen before Christmas. Thank you. But in calling for that, I clearly ended up on the radio and the TV, so I was called in not only by my ministers to explain myself, but I was called in by the Cabinet Minister for Policy, who said, this is really important. And I said, yes. I think it's like climate change. We're doing it to ourselves. We could stop doing it to ourselves if we restrained ourselves. Yet, we aren't. We're just watching it happen, and we need to do something. So he's been absolutely fantastic. So he said, right, the government strategy, cross-government strategy, the second one on antimicrobial resistance, has to respond to your report. We will do some more work before we put it out and make sure it does. And now the Prime Minister has made it one of his research priorities, one of his priorities. And why do I care about this so much? Well, resistance is here. It's here to stay. It happens as a result of natural selection, Darwinism. I think it's absolutely fascinating that the multiplication time of bacteria is about 20 minutes, so you can see how they multiply terribly fast. But also, I'm learning lots, they put out a kind of proboscis, a kind of penis-type extension, some of them, and shoot little circles of DNA with the resistance into other members of the same generation, so they can multiply too. So it's a really big issue. It happens rather easily. And then, when you think about it, it must be causing rather a lot of infections and deaths, and we've found that in Europe there are at least 25,000 deaths, which adds a big cost. We modelled it in Britain, and just for one particular bug, E. coli, we modelled at least 5,000 extra deaths a year. Deaths that shouldn't happen. 5,000 families with a tragedy that is wrong. We should have watched it happening and done something, not watched it happen and say, oh dear. But I think no one before had kind of put it together and blown a whistle, blown time. And you can do something about